Part 2. Specific neoplasm-like lesions of bone. Osteoma, ivory exostosis. It is a rare lesion developing on the surface of cortical bone, where the predilections are skull and tibia. The radiograph showed as an tagged X-ray, and no treatment required unless the lesion presses on significant soft tissues. Single Osteochondroma or osteocartilaginous exostosis. It is benign neoplasm where there is abnormality of growth direction and remodeling in the metaphyseal region of long bones in growing children. The common sites are lower end of femur, upper end of tibia, and upper end of humerus. The protruding lesion always points away from the nearest epiphyseal plate, consists of normal bone kept by normal cartilage. There are two types of single osteochondroma. The first one is pedunculated or stalk type, which is long with a narrow base, and the second one is sessile type, which is short with a poor base. There might be malignant change, which called chondrosarcomatose, and accounts 1% of cases in adult life. It is not painful, but may interfere with the function and also limit the joint motion. The radiograph reveals only the bony part, and the lesion is always larger clinically than it appears on radiographically. Not all require treatment unless producing ugly lump and interfere normal function, and there's where surgical excision is needed. Osteoid Osteoma. It is reactive bone lesion rather than true neoplasm, were characterized by persistent pain, developing in children and adolescents, especially boys, and occasionally in young adults. The predilections are bones of the lower limb, predominantly femur and tibia. The lesion consists of a small round nidus or a nest of osteoid tissue surrounded by reactive bone and doesn't continue to grow, and the size is larger than 1 cm. The symptoms are mild and nagging pain and more noticeable at night, relieved by mild analgesics. There is radiograph examination that is really essential, which is scintigraphy. This kind of disease is not progressive and may even self-limiting over many years, but if there is any persistent pain, it is usually needs surgical excisions guided by percutaneous CD. Osteoblastoma or giant osteoid osteoma. It is much larger and it's benign osteoblastoma, developing in vertebrae and flat bones, which relatively little sclerosis consists of osteoid. It's more likely painful and best treated by surgical excision following by bone grafting. Osteofibrous dysplasia or Campanacci syndrome. Characteristic site is tibia. It is rare and unusual lesion. Bony, hard swelling on the anterior surface of tibia, which is already bowed anteriorly. The radiograph showed a bubble-like appearance, and the treatment is resected and the residual defect requires bone grafting. Aneurysmal bone kiss or ABC. It is not a true neoplasm, and it's found in adolescent and young adults, especially in the spine. It is locally destructive and rapidly erodes cortical bone from the inner surface. The lesion contains vascular tissue rather than mere fluid. If left untreated, it may reach an alarming size and may even rupture, producing hematoma, expand rapidly, and it become painful and tender, where pathological fracture is not uncommon. The radiographic showed large expanded osteolytic lesion, and the treatment is curettage and bone grafting with the help of arteriography. Simple bone kiss, where we can call it unicameral bone kiss or UBC. It is common in children and adolescents. The predilection sites are proximal humerus, distal femur, proximal tibia, and distal radius. Kiss develops to the epiphyseal plates and it spans to fill the entire metaphysis and even diaphysis. Cortical bone is resorbed from the inner surface, but prestial reactive bone on the outer surface contains the lesion. The cavity is lined by non-neoplastic connective tissue cells, and it's filled with serous or serous film. The overlying cortex becomes markedly thin, and the pathological fracture is common. Expands slowly and painless. As the cyst becomes more mature and less active, it stops enlarging, in which case the epiphyseal plate grows away from it due to self-limiting process. The most appropriate treatment of SBC is curettage and bone grafting. Specific true neoplasm of bone. Osteosarcoma or osteogenic sarcoma. It is an extremely malignant neoplasm which arises from primitive cells in the metaphyseal region of a long bone in young individuals. The second most common primary malignant neoplasm of bone. The most consistent symptom of rapidly growing osteosarcoma is pain, which is initially mild and intermittent, but becomes progressively more severe and constant. The most accurate form of diagnostic imaging to determine the intraosseous and extraosseous extents of the sarcoma is MRI. These are the pictures of osteosarcoma. The first one is pathological fracture showing an osteosarcoma in the lower end of the femur of a 9-year-old girl. The annulated fracture is beginning to unite by subbrachiosapical callus despite the presence of the rapidly growing malignant neoplasm. Note the soft tissue mass containing neoplastic bone and the Codman's triangle of reactor bone posteriorly. The second picture showed osteosarcoma in the metaphyseal region of the lower end of the femur in a 10-year-old girl. Note the combination of bone resorption and the bone deposition. This particular osteosarcoma is predominantly osteolytic, but some neoplastic bone is beginning to form beyond the confines of the metaphysis. A Codman's triangle can be seen in the lateral projection. Chondralchondrosarcoma. Chondralchondrosarcoma is usually a relatively slow-growing malignant neoplasm that arises either spontaneously in a previously normal bone or as the result of malignant change in pre-existing non-malignant lesion such as an osteochondroma or an enchondroma. Chondralchondrosarcoma grows relatively slowly, so pain is not a prominent clinical feature. Fibrosarcoma. Fibrosarcoma is an uncommon malignant neoplasm that may arise in a long bone in young adults, either as a primary neoplasm or secondary to radiation. The principal sites are the femur, the tibia, and radius. This is the picture of fibrosarcoma in the radius of a 28-year-old woman. Note that there are several well-demarcated osteolytic defects, all of which are part of the same neoplasm. Ewing tumor or Ewing sarcoma. It is a rapidly growing malignant neoplasm that arises from primitive cells of the bone marrow in young persons. Beginning within the medullary cavity, Ewing's tumor soon perforates the cortex of the shaft and elevates the periosteum. Ewing's tumor grows so rapidly that it often outgrows its blood supply, and consequently central areas of the neoplasm become necrotic. This is the picture of Ewing's tumor or Ewing sarcoma in the shaft of the femur in a 6-year-old girl. This neoplasm is in an early stage of its development and it's only moderately destructive. Note the radiographic onion skin appearance of periosteal reactive bone on the lateral aspect of the lesion. The prognosis of Ewing's tumor, like that of osteosarcoma, is extremely grave. The chemotherapy may include vincristine, actinomycin D, doxorubicin, or cyclophosphamide. Giant cell tumor of bone, or Osteoclastoma. It is a potentially malignant and sometimes frankly malignant neoplasm that arises in the cancellous end of long bones in young adults. The origin of the osteoclast is not known. Formerly, several benign neoplasm and even non-neoplastic lesions that contain osteoclast or giant cell were considered to be giant cell tumors. Now, that these less serious giant cell variants have been excluded, what remains as a true giant cell tumor is a formidable neoplasm. Giant cell tumors are locally destructive neoplasms. The cancellous and cortical bone are resorbed from the inside and simultaneously. The periosteum deposits bone on the outside so that the end of the bone eventually becomes expanded. The patient complains of local pain, this variety of which is related to the rate of growth of the neoplasm. Because the lesion abuts the articular cartilage, there is nearly always some disturbance of joint function. Giant cell tumors have a disturbing tendency to recur after logical surgical treatment such as simple curettage. For the most aggressive giant cell tumors or for local recurrence, radiotherapy is one option that can be used in an attempt to avoid amputation. This is the picture of giant cell tumor of bone or osteoclastoma in the lower end of the radius of 32-year-old man. Note that the destructive osteolytic neoplasm includes the site of the former epiphysis and extends to the subchondral bone. In this relatively early stage, the radius is just beginning to expand on the medial or ulnar side.